Welcome to the MS&Me Radio Network, a division of the Multiple Sclerosis Global Support Network. The following program broadcast is an original creation by the broadcast entity. Discussion within the following broadcast should be used for informational purposes only and is not a substitute for professional medical advice or consultation. Before considering application of any broadcast content in the following program, please consult your healthcare provider. If you feel you are having a medical emergency, please contact your local health services for immediate assistance. MS&Me Media and the Multiple Sclerosis Global Support Network do not guarantee or warrant the accuracy of information in the broadcast to follow. The Multiple Sclerosis Global Support Network provisions broadcast services to program hosts. Information discussed in the broadcast does not necessarily reflect the views, opinions, or goals of the network and are solely those of the show broadcast host. Should you wish to host a broadcast, please visit our website at msmemedia.com and submit a request to become a program host. We thank you for listening to the MS&Me Radio Network. Enjoy the show. Get ready for Ask MS&Me. Have an MS-related question you want answered by your fellow MSers? Use hashtag AskMSME on any of your social media accounts, and we'll get as many answered as possible. Get ready. Here comes Ask MS&Me. Welcome to Ask MS&Me. Joining in the fun today is Anisha Hankins, and I'm Erica Richardson. Welcome, Anisha.
Thank you, Erica.
This show's all about your questions being answered from the point of view of fellow MS patients, and you can submit those questions each week by using hashtag AskMSME on your social media accounts. Or you can also contact us through our website, www.msandmemedia.com. So let's get started for this week. Let's see if we have a question that has come in off of social media. Yes, our Facebook info hub. The member says, I have a question for all of you that fight MS. As yet another new symptom has reared its ugly head, I ask if any of you have experienced this for yourselves. I am now suddenly getting a feeling of warm water running down random locations, behind the knee, neck, shoulder, and forearm, including my hand. I've had the ice cold sensation for a long time, but mine feel like ice razors cutting. This just started and truly feels like very warm water coursing down. I would appreciate any feedback as I deal with this. Thank you so much in advance. You know, unfortunately, another sign of nerve damage that can signal new activity in your spine are the symptoms that you've been describing. I would definitely discuss this with your physician. Arachnotitis, it's a pain disorder caused by the inflammation of the arachnoid. It's one of those membranes that surrounds and protects the nerves of the spinal cord. It's characterized by kind of severe stinging and burning, neurological problems. So if this is a new issue, like we said, this is definitely a discussion for your physician. Anything that's new and lasts more than 24 hours and it's been at least 30 days since your last relapse, that's something you want to call your physician, your care team about. Let them know. If anything is such a severe new sensation or symptom of vision, like losing your vision, losing use of a limb, then that's boom, trip to the ER. You have someone else drive you there. So that's definitely something you want to discuss with your physician. Anisha, do you see another question coming in off social media?
I do. It looks like from the info hub, it says, hello. Has anyone had a lumbar puncture that did not get a headache? Well, that's a great question. I just recently had a lumbar puncture or spinal tap, as most people know it, done. A spinal headache can occur as a result of a procedure such as a spinal tap or an epidural block, which is used to perform when people have, when women have children in labor and delivery. Also, a spinal block can be used to perform surgery on lower extremities, even upper extremities, arms or legs. They can block a certain area to be able to get to it by blocking the nerves. In these procedures, a needle is placed within the fluid-filled sac space surrounding the spinal cord. This creates a passage for the spinal fluid to leak out, changing the fluid pressure around the brain and the spinal cord. If enough of that fluid leaks out, a spinal headache could very well develop. Because the design of spinal needles has been improved over the years, spinal headaches after a spinal tap or administration of spinal anesthesia are pretty much now rare. When epidural anesthetics are placed with a larger needle than that used for spinal anesthetics, however, the likelihood of a headache is higher if the epidural needle should inadvertently pass through that dura mater, which is the matter that covers the spinal cord. So if it sometimes passes, a person could still experience one. Without treatment for a spinal headache, it could resolve on its own within 2 days. Sometimes it could take a couple weeks. Mm-hmm. To me, it really depends on the person, if they can really, withstand it or not. I've heard some people tell me it was so bad that within 24 hours they were right back at the hospital. So for some people, it can and will resolve on its own. Mm-hmm. The first course of treatment for spinal headaches, it involves supplying adequate hydration to try to increase the spinal fluid, the CSF pressure back in the spinal cord. That's very important. That's why it's key to stay hydrated whenever you have MS. Just stay hydrated in general, because a lot of times when people become dehydrated, one of their signs is a bad headache, okay? And so it's important to stay hydrated. Sometimes IV fluids are given. Other times, a person is advised to drink Mountain Dew, coffee, anything that contains a lot of caffeine, mm-hmm. because caffeine is known to help get rid of headaches. So that's another piece of advice that doctors will often give. Strict bed rest for 24 to 48 hours could also be recommended by the physician as well. In some cases, a few, gabapentin, hydrocortisone, theophylline may be prescribed if conservative treatments aren't working. Let's say they've tried the caffeine, the hydration, getting back hydrated to increase that spinal fluid back up, and that's still not working. They may try a course of gabapentin or hydrocortisone to see if that will help. Also, if a person develops a spinal headache following the procedure, the anesthesiologist can create what's called a blood patch with the person's own blood to fill that leak. To administer a blood patch, the anesthesiologist inserts the needle into the same space as or right next to where they went in to, draw the blood for the spinal tap, and then they inject blood back into that area, and the blood is from you because they'll, draw from your arm or draw from your IV line if you're an inpatient, and inject it into that epidural space, and then it will clot and it'll make a hole that is causing that leak of that spinal fluid, which is giving you that headache. When I just had my spinal tap or lumbar puncture, as most people call it, done a couple months ago, my instructions by my doctors were to lay there for 30 minutes after I got done, flat on my back after they were finished for 30 minutes, and then, go on about my merry way. Of course, not continue with anything strenuous or bending over a lot, things of that nature. But I had zero side effects, no headache, no nothing. So I've been afraid of it for many, many years, and it's definitely come a long way.
It really has. It's changed a lot. I've had two. I've had two of them, of spinal taps. The first one, I was in the hospital, and of course, I laid down, adequately, of course, because I was in the hospital bed, and I was well hydrated, because I had been on IV fluids. The second one, I was working at the time, and had scheduled it, as an outpatient procedure. And as I tend to sometimes do, get dehydrated and not watch my fluid intake, I unfortunately did have a headache the second go around. And I do think it was, because I didn't have the time to lay down long enough afterwards. And for me, it's better if I lay down for an hour. I don't know, most people are adequate with a half hour. Me, because I have a history of migraines, I think that the whole hour is really good for me. But I went right back to work, which I shouldn't have done.
No,
Yeah, I know.
no.
I know. Bad, 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 bad thing to do. So I ended up with days worth of headache. Had to drink caffeine drinks the whole nine, and take anti-inflammatories. So it wasn't pretty. So definitely following protocol is the key. And I think that's a lot of time where people get into trouble. Because like you said, it's improved. It's greatly improved over the years. And if you follow protocol and there's no, outside things going on with you and your health, it's usually an easy peasy thing now. But it's that fear of the past, like you said, a lot of it's fear of the past. And when we didn't know, and when, needles weren't improved, this, that, and the other. And I think that if you follow the protocol, and like I did, it really
Yeah.
can be just an in and out kind of thing. And it's a great diagnostic tool. It's just one in the arsenal that they use for diagnosis, but it is a great tool, and is still used in most countries. It's still used.
Mhm.
Okay.
And I really,
Yeah, go ahead.
I even asked them, I was like, 30 minutes? That's all? I just need to lay here for 30 minutes flat on my back? Because that's like not how it used to be. You know what I mean?
Right.
So
right.
they've absolutely come along. And I had not even a peep of a headache. None. Mm-mm.
Yeah, I'm hearing that more and more. It's just boom, boom, and it's so easy compared to the old days. Most of the advice you will get is from patients who had it, far in the past, and things have improved so much that you won't have the same experience as they had, before things were improved. Much like, with medications and treatment, you'll often hear advice, and it's from patients who haven't experienced the newer treatments. And things have really changed. They've really been improved.
Mm-hmm.
Okay, do we have another question coming in, Anisha?
We do. In ladies, I've been accidentally biting my tongue a lot lately, and a lot is how she has it. Lot is in big letters. Is that an MS thing too? Well, certain clinical manifestations affect the oral facial region, and when you hear someone say oral, that's that mouth, the whole mouth region. 3 in particular should be of interest to the dentist: trigeminal neuralgia, otherwise known as tic douloureux, sensory neuropathy of the trigeminal nerve, paresthesia, and also facial palsy. Trigeminal neuralgia usually appears after the diagnosis of multiple sclerosis has been made. In some cases, it's present in about 1.9% of MS cases. It is, however, the first manifestation of the disease in about 0.3% of cases. So that does seem really low. And I think, honestly, the reason why that is because people are having that pain and they don't know what it's from.
Yeah.
They have no idea, right? And it's just getting that whole workup, and then they figure out, oh, well, it's MS, and oh my gosh, you have trigeminal neuralgia. But compared to conventional tics, which is unilateral, it's usually on one side. Trigeminal neuralgia is caused by multiple sclerosis. It can be bilateral. It can be on both sides because of multiple sclerosis. The pain is paroxysmal, which is described as being like an electric shock, and it can be provoked by touching your cheek. That simple. Touching the cheek, brushing your teeth can cause it. just as simple as brushing your teeth. That's how people don't understand how this disease can be so tricky, and like things that you used to be able to do with no issue all of a sudden causes complications. So think about it. Someone who's just simply going to brush their teeth can cause their trigeminal neuralgia to act up. The pain only lasts for a few seconds, but that's not in all cases, because it can return several times during the day. The pain is so bad with trigeminal neuralgia that most people will tell you that pain, they're literally like, oh my gosh, this is it. I never thought this was going to be the end. Yeah. Like, the pain is above a 10 for them. It's eye-watering. I've had men tell me that the trigeminal neuralgia pain is enough that it brought them to their knees. So they kind of compare that pain to that of passing a kidney stone, okay, that pain is that bad. It's important that the dentist can distinguish the pain from other types of facial pain. And it's important, too, that we're, talking about kind of the dentist here, because a lot of people will go to the dentist for years because they're having pain in their teeth, in their gums, in their face, and they think that they have a bad tooth when that's not it. They actually have MS, okay? And it's their manifestation of it is in that oral facial region, okay? That's where it's showing up at. I know I personally kept going to the dentist thinking I had a bad tooth and I maybe needed a cavity for, filling for, and I didn't, for many years. They're like, no, you have beautiful teeth. I'm like, well, something's wrong,
I had the same exact experience. They actually, in college, fit me for a mouthpiece. And thought that that it was TMJ, or they thought of everything else instead of the TN, because I had bilateral TN, which is unusual, and especially to start off with, and mine lasted more than the few seconds, so it was a classic case, so it really threw them off. But that's not that unusual for the teeth to be one of the first symptoms.
Right. And mine, it'll get me in the ear. It'll feel like someone has hit a baseball with a baseball bat deep inner ear, and then it comes through to that jaw, then right around. It's horrible. Horrible. That pain is pretty bad.
Mine has progressed to the point that even my hair, falling against my face, that's enough to set me off. And the nickname, if you guys haven't heard, the nickname is actually the suicide disease. I know that's a horrible thing to say, but that is the nickname of that disorder, is the suicide disease. And obviously, if we talk about it and we get treatment, that doesn't have to be the case, because there are options. Anisha, can you give more information?
Yeah. The reason why it's called that, because honestly, that pain is so bad that people want it to stop, and they honestly will say, you know what, this pain is so bad, I would rather kill myself, and just to get it to stop. And unfortunately, many have done so. So that's exactly why it is called that. But, the more we talk about it, the more we, let people know, what's out there, what comes with MS, all those things, and awareness of this disease and what comes along with it. And you can, talk to your doctor, talk to your dentist, all of that. Because, again, everyone should know what's going on with you. There's help. There is help. There's help for it. Also, sensory neuropathy, secondary to multiple sclerosis, it can be progressive, as Erica talked about earlier, and it is irreversible and bilateral. That's how hers is, okay? It's on both sides. You can't reverse it. It's so sad. It's so sad. But, that's why, again, that term that people nickname it, that Erica, brought up, that's why. It preferentially affects the second and third divisions of the trigeminal nerve. Onset is sudden, and sometimes it's accompanied by pain. And I'm going to say, when people say sometimes, I'm going to say most people I know.
Most of the time.
So it's all the time. There is no sometimes,
Yeah.
It hurts.
It really does.
Yeah. Yeah.
Yeah, my husband
Neuropathy.
actually has it from a car accident in childhood, and he has it on one side. So his hasn't thankfully progressed to two sides because he doesn't have a progressive disease like we do. So his is just the damage on the one side that was damaged during the car accident, and it really, like you said, with some men they don't often admit to their level of pain, but it brings him to his knees. I have seen him take a knee. So it's really sad. It really, really is.
Yeah. Neuropathy, and because think about it, there's parasympathetic, there's sympathetic, then there's parasympathetic pains and nerves. But neuropathy of the middle nerve can cause numbness of the lower lip and the chin, and that's with or without pain. So one thing that I was able to figure out is, well, not able to figure out, but whenever I go to the dentist and I have to be numbed up for some reason, like I have spaghetti lips for like 24 hours afterwards.
Yeah.
You know, it does not just go away. Like for somebody who doesn't have MS, a couple hours, they're good. You know, I'm still like, you know, a mess up to about 24 hours later, you know?
Yeah. There's still water spilling out when we try to drink. If we try to eat, we're dribbling. Yeah. It's not uncommon for MSers.
Yeah, it does. It takes a bit for that to come back. The differential diagnosis is complex, so always remember that. It can be a complex thing for people to be able to hone into it. Paresthesia can be provoked by local trauma, as Erica talked about with the accident that her spouse had at childhood. That's trauma, that induced it. Lesions in the mouth area can cause it. Neoplasms of the jaws or of the central nervous system or cerebrovascular conditions. It also arises from neuropathy secondary to AIDS and other systemic conditions. The differential diagnosis should include collagen disease, sarcoidosis, syphilis, osteomyelitis, and neuropathies caused by certain medications. Because please remember, too, that certain medications can cause neuropathies as well. Facial paralysis appears later in the course of the disease. Remember, this isn't going to be textbook for everybody. It's not going to be textbook for everybody, but for the most part, it occurs later in the disease. It may be difficult to distinguish between the paralysis caused by MS and that due to Bell's palsy, because Bell's palsy can also happen because someone has MS. So it can be a little bit tricky. And up to 24.3% of people with MS at some point may experience some form of facial paralysis. So that's, pretty low number, but if you're one of those 24.3% of people, it's no fun.
And waking up every day, sometimes from your sleep, and both sides of your mouth inside your jaw are just swollen because you've bit them, continuously through the night, and you have big sores inside your mouth. It's not fun. It really hurts.
Right. And then, too, taking a look at how it works with the spinal tap, because a lot of people will, now with technology being the way that it is, and they'll have, the results of their spinal tap before they even, go back to see their doctor for a follow-up,
Right.
So they're like, got this question, and what does this mean, and what does that mean, blah, 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 blah. And it's like, okay, hey, these doctors know exactly what they're, looking at and what they're seeing. And that spinal fluid tells a lot, not only about neurological diseases, but also things that are rheumatological as well. So when you look at that, diagnosis usually follows detailed clinical examinations and special tests, and is usually confirmed by specific diagnostic imaging techniques. Analysis of that cerebrospinal fluid, CSF, which I was just talking about with the spinal tap, it's often used to confirm that diagnosis. The CSF is abnormal in 55% of cases. The level of immunoglobulin is greater than 13%, which means it's high, while the level of lymphocytes and proteins will be slightly elevated as well. These changes are not, however, However, these changes does not, specifically say, this is MS, this is not MS, because they're going to be looking at MRIs as well. Okay. But again, an MRI is the most sensitive and effective way of detecting a demyelination disease course of the central nervous system. To treat, manage the symptoms of the condition to improve the quality of life, because that's what's rough. If you're all of a sudden biting your tongue every time you eat, then you've got holes in your mouth and it burns if you eat something salty, or, that just messes with your quality of life overall. So the objectives are to prevent relapses, slow the progression of the conditions, reduce the severity and the intensity of the disease progression. Chief treatment modalities focus on the control of the symptoms and on the disease itself. The treatment often requires the use of steroids, as we talk about quite often. Right. And again, steroids kind of aren't for everyone, which I'm sure Erica talked to you guys a little bit about a little bit. Steroids aren't for everybody, because there are some, side effects to those that can be pretty nasty. Interferons, like your beta-seron, things like that, those are interferons. And if you look at that word, because some of these terms, you're like, interferon, what do they mean? If you look at it, at that beginning root word is the word interfere. That's exactly what that medicine is designed to do. It's designed to interfere with attachment to certain cells, okay, to prevent progression. And also immunosuppressors, which are most of these interferons, they are immunosuppressors. Plus, the pills, things of that nature, you do become immunosuppressed. One of the principal steroids, of course, is prednisone. It counters the progression of multiple sclerosis and has anti-inflammatory properties. It's taken orally, has numerous side effects, but also, as we know, steroids can be administered intravenously over a short period of time, and then subsequently taken orally. Now, when they do IV steroids, I've seen some people have 3. I've seen some people have 5. I've also seen some people, I know I myself have had to have 7, because I had so active at one time. I had to, bite it and have 7. And they used to do a taper down off of IV steroids, but some, now with looking at research, that taper dose, some doctors don't do it anymore, because it's found that it didn't, do anything, so what's the reason, to expose anybody to any more of it, So it just depends. Dentists should be careful when treating patients on steroid therapy, so always make sure that you if you have a dentist appointment coming up for your teeth to be cleaned or anything like that, and you know that you've been on steroids, you need to give them a call and leave a message for the dentist, or have the dentist give you a call, because you do not want to deal with adrenal atrophy, because if that happens, it can cause shock, nausea, vomiting, abdominal pain, diarrhea, and it could lead to death. So that's not something that you want to have.
Never play around with that, ever.
Don't ever play around with that. You want to make sure all doctors know every single thing that is being done, okay? And also, too, whenever you're on steroids, you're more prone to infections. Always remember that as well. I'm sure a lot of you have probably heard when doctors say, well, because there's a certain thing called nosocomial infections. And what nosocomial infections is, those are infections that people pick up when they're in the hospital. Go figure. You think you go to the hospital to get well, but there's classification of infections that are called nosocomial infections, and that's because you picked them up because you were in the hospital. So it's very important to remember that. Also, it's important to avoid prescribing aspirin and NSAIDs, which is your non-steroid anti-inflammatory meds, for patients that are using steroids, because, again, the gastric issues, I'm sure a lot of people say, man, my stomach's upset, blah, blah, blah. Whenever you're on steroids, you want to stay away from, acidic juices, these NSAIDs, stay away from them, because that can end up, again, gastric issues, and you don't want to end up with ulcers.
Mm-hmm. Yeah. And I get the gastric upset for mine. Unfortunately, at this point in my progression, I've had so many decades of steroids. My body's reacting each time that I need them now. So I've actually foregone them this time. I'm actually in a relapse right now as we're talking, and it was brought on by Hurricane Irma and the stressful situation of evacuating, and I had just gotten over the flu, so my system was weak. And unfortunately, I've just had to choose not to do the steroids this time. I had the blood sugar issues with steroids, heart issues with the side effects of steroids. It can mess with blood pressure, heart rate, blood sugar, insulin level, all kinds of things. And once your body and you can also have an allergic reaction to steroids. And there are alternatives.
Right.
There are alternatives like the Actar gel, which is very expensive and not always covered by insurance. So that's not always an option for everyone, but it is definitely something to ask your doctor about. Some people choose, natural ways to kind of suppress their immune system when they're in a relapse, and they just try to ride it out. The thing is, if you're making these decisions without involving your care team, you're playing Russian roulette, because you don't know exactly what the activity is doing to you when it starts. And sometimes it can be too late to totally suppress the damage and stop it in its tracks if you wait, to choose an intervention course. And you don't know exactly where the lesions are necessarily located that's causing the activity. You don't know how large they are. Do you want to play Russian roulette with your sight or your ability to walk, or any of those, any of your senses, any of your abilities?
Right.
During one relapse, I lost complete central line control. I have no trunk control. So you don't want to play that Russian roulette. And I think you can make the decisions you want to make. It's your life, your body, but make them at least with the advisement of your care team. They know you best. You might want to have diagnostics done before you make that decision. Not just say, okay, I'm not going to go to the hospital, or I'm not going to tell my doctor. Make it in conjunction with your care team and get the total picture. So you make an informed decision, even if you're going to make one that, might go against your doctor's wishes. At least make an informed decision. Too many of us have been deciding, oh, well, we know what all, steroids do to us, so I'm just not even going to do it this time. I'm going to write it out. It might be that time when you have that big relapse you weren't expecting. You might thought, oh, well, last time this just got tingly and this and that, got a little bit weak, but it resolved. It's not the same relapse every time. It's not the same lesion location every time. It's not the same size of lesion every time. And it doesn't even matter the size. It can be a tiny one, but it's in the wrong location to where you lose some major function. Do you really want to play that game? So I have made that decision informed for myself, and that's the best decision for me this time. But make sure you are keeping everyone in the loop while you're making that decision. And I was in the hospital when I made that decision. So let's keep that in mind. Let's not stay at home and say, oh, well, I think I'm going to do this. Let's let your care team know, get any diagnostics you might need, and then let's make the decision. Okay? So I think that's the mistake many of us make. All right, let's see if there's another one coming in off of social media. This one is actually from our Facebook group. It's MS&Me Ladies Only Facebook group. It says, hey ladies, I've been vomiting off and on for the past few months. Ooh. I've seen my doctor to see if I had an ulcer or anything weird, and it's not any of those, so I'm wondering if it's related to MS. I was recently diagnosed and I'm still trying to figure out which symptoms are caused by it, meaning MS. That's a very good question. Once you've been to the doctor, to any specialist that were ordered and test, and they have not found a root problem outside of MS, then of course, you might want to start considering MS and mention that to your neurologist. Vomiting can have many root causes. Some can be MS related. Some patients living with MS experience nerve damage, leading to gastroparesis and slow digestion. Some problems, nausea, vomiting symptoms are induced by perception of any kind of movement in the patient's field of vision when they have multiple sclerosis. The symptoms begin abruptly with intense nausea, and if the triggering movements persist, the vomiting soon follows. So, movements of any kind, however, with your eyes closed, the symptoms stop, it just disappears. So, lesions can be present in the vomiting center of the brain. Yes, we do have a vomiting center of our brain. For example, a large lesion can be present, there and occupying the posterior portion of the brainstem, including the medulla. The hepatic spread, arguably the most accepted explanation of paroxysmal symptoms in multiple sclerosis, could certainly involve the vomiting center. And, the chemoreceptor trigger zone in that area of the prostrema, definitely a discussion that you should be having with your physician. Your MS specialist, your neurologist should be involved. Because you just shouldn't sit there and suffer like she has, unfortunately, for months. And okay, I had the test, from my gastroenterologist, that was cleared. Now what? If something's not resolved, then we go back to our neurologist when we have MS, to our rheumatologist when we have lupus, or whoever is seeing us for other conditions, and we see if it might be root cause from that condition and not necessarily primary to just like a gastric issue. Me personally, I have gastroparesis, and mine is from the nerve damage from my multiple sclerosis. So that is usually the root cause when I have nausea. And I throw up quite often, unfortunately, at this point. I have to eat a special diet. I malabsorb my protein. There's all kinds of things that can go on gastrically when you get more advanced, or if you just happen to have damage in that area early on in your progression. So definitely don't just fluff these off as, okay, they didn't find anything in the first test from the first doctor I was sent to, so I just have to live with it. You shouldn't just have to live with it without seeking those answers. Because, yes, sometimes there isn't much we can do besides trying to control maybe diet and reaction to things, but sometimes there are things that can be done. So you don't want to just, dismiss things like that. So my suggestion to you is if you get we didn't find anything, go to your other physician and say, hey, they didn't find anything here, so now what? Where do we go from here? So that would be my advice. Yeah, that would be mine.
That is correct. As you know, I dealt with this, dropped 40 pounds,
yeah.
And had to see a gastroenterologist and then had to have surgery and all this other stuff, and they were able to find, H. pylori, on top of some other things that I don't really talk about too much just yet, but they found some things that were definitely wrong, in the tummy that were not, MS related.
Yeah.
It might have been, because of, some meds sort of thing, but it took, having good doctors that all worked together to find what was going on. So please just don't sit and say, well, I guess I'm just going to have to deal with this because they said it's nothing. Please don't do that.
Yeah.
Please don't do that. Please advocate for yourself.
Absolutely. You can find, perforations they didn't find because they just did an endoscopy and not a colonoscopy. You could find cancers. You could find all kinds of things going on. And like Anisha said, it could even be side effects from your medications Or it could be other things. You just might have had a genetic disposition towards something, and then things with our diseases might have irritated that and caused the perfect storm for that to happen to you. So never let anything go. Even exploring things with our multiple sclerosis can sometimes uncover other medical diseases, disorders, conditions that sometimes can save our life. So never
right.
let the answer, just sit there and go unanswered, the question go unanswered. So definitely speak with your physician about that. Okay, Anisha, do we have another one coming in?
We do, from hashtag #AskMS&Me.
Great.
I made the mistake of sitting on the floor with my legs under me. I do it all the time and end up with bad pins and needles. This time I had pins and needles along with horrible leg cramps that hurt so much. Is this an MS thing? Well, yes, this can be an MS thing, and it can also be an issue with a vascular issue. This is why I strongly advise seeing a doctor. Again, a lot of times we will make the mistake because sometimes we even have some physicians that will be dismissive, which in turn makes us be dismissive too, and we'll end up just lumping everything that happens to us, it's because of MS, when it's not. It could be because of something else, okay? So it's very important that you know your body and you know that when something is wrong and it's out of your normal, even say, for example, you would get bad pins and needles, but then all of a sudden, here's this bad cramping and all of that. That's something different for you. Please, please, please go and talk to your PCP or PCM. It's called a GP in other countries. Go, talk to them.
Mm-hmm.
Then see about, what other specialists they can get you sent to figure out why this is happening. It could be spasticity. Spasticity is a beast. What it does, spasticity refers to the feelings of stiffness and a wide range of involuntary muscle spasms. They also can contract, or they'll cause sudden movement. Okay. For example, I'll always hear people say, "Oh, I have a Charlie horse." I wish.
Yeah.
When I think back to when I was a kid and I used to have Charlie horses and I could drink that pickle juice, and although it was good, to get rid of, Charlie horses, guess what? For spasticity, that does nothing. Because spasticity is like a Charlie horse on crack. Seriously.
Yeah.
It is totally bad. It is bad. And it's definitely something that you want to, get under control. Spasticity is one of the more common symptoms of MS. It may be as mild as the feeling of tightness of muscles, or may be as severe as to produce painful, uncontrollable spasms of extremities, usually of the legs, okay? Me personally, I get spasticity in my toes. My toes will look like piano keys by the time they're all done twisting and contorting. I get it, in the ankles, the foot area. I do get them in my legs. I also get them in my hands very bad. It's something else. It really is. Spasticity may also produce feelings of pain or tightness in and around joints and can cause low back pain. Remember that. It can cause low back pain.
Yes.
So, in other words, what we're saying is if you have low back pain, don't just say, well, my lower back's been hurting and I'm not sure why. These are things that you need to discuss with your care team. Mm-hmm. You've got to let your doctors know and make them aware of what is going on so that they can be on top of your disease and doing things to help with symptom control and also progression. Mm-hmm. Although spasticity can occur in any limb, it is much more common in the legs. But like I said, I do have it, in my hands because, again, from my cervical neck on down, it looks like Swiss cheese. That's exactly the way the doctor said it. He's like, honey, it looks like Swiss cheese. There's just holes all in it. Most of the muscle cramps develop in the muscles, particularly in the calf. But again, note, some people, it's going to be different. Besides the sudden sharp pain, you might also feel or see a hard lump of muscle tissue beneath your skin.
Yeah.
And definitely you see it. You're like, oh my gosh, look at, just like I see the contortion of the toes and, my thing, you see it. It's there. And it can also hurt for a few days after, because it was so bad.
Yeah, it's sore. It's really sore. Just even moving, stepping, reaching with your hand, trying to move your wrist. It's sore for days and days sometimes.
Yes. Yes. And one thing, a question that I think that a lot of people ask themselves is, well, when do I see a doctor about this? Well, muscle cramps usually disappear on their own and are serious, they disappear on their own and they're rarely serious enough to require medical care. However, if it causes severe discomfort, it's associated with leg swelling, redness, or skin changes, associated with muscle weakness. They happen more frequently. Don't improve with self-care, meaning like you're massaging, and don't get me wrong, sometimes trying to massage it or walk it out is just not the thing to do.
Right.
One thing that I figured out that kind of helps me, only in certain areas, Vicks Vapor Rub works better for me than any type of sports cream. If I get one like in my calf, for some reason that works better for me in self-care. And if these, cramps, if they're not associated with an obvious cause, like you've been wearing high heels all day, you've been, doing some strenuous exercising or something like that, there's no overuse of the muscle. You're not dehydrated. You have not strained or sprained anything. You're not holding in a position for a long period of time because that can cause a cramp. Like if you just sit on one side of your butt for so long, or when you're driving in the car for a long period of time or riding and you kind of start, ooh, I'm getting crampy and you need to move around. If you're not doing that, that's whenever you know that you need to go and speak with your doctor about that. And remember, in some cases, the cause is going to be, it's not going to be known, but that's okay. At least an eye can be kept on it, because most likely it probably is spasticity, and it's just part of the disease process that you have.
And I want to interject here just a second. I'm sorry for interrupting, Anisha, but sometimes these little clues, not always in of themselves, but with other things, if you keep your care team abreast of every little new thing that's happening to you, you journal your symptoms and anything new you mention or anything that's increased in severity or in the time that you're getting it, you want to mention these because they can be a clue to new activity that was not caught and that was not, so huge that a whole limb went limp, but all these little clues can give them, a kind of a picture into deeper damage that's not always readily visible, because not all damage is visible, even on scans. But if you tell them, well, this is happening here, and my eye's crossing, and this, and, and I'm getting increased spasticity, it can be a clue to greater damage that you might think's benign, but it's like a piece of the puzzle to them, and they go, I think I know what's going on here. So keep that information flowing to your physicians at all time.
Yes. And that's so true. Because, although, most muscle cramps they're harmless,
right.
Sometimes, like I said, where we sometimes want to tell ourselves, well, it's just because of MS. That could not be the case because sometimes there could be an underlying medical condition, inadequate blood supply, narrowing of the arteries that deliver the blood to your legs, arteriosclerosis of the extremities can produce cramp-like pain in your legs and feet while you're exercising. And those cramps will usually stop as soon as you stop exercising. They'll stop. Nerve compression is another thing. Compression of the nerves in your spine, lumbar stenosis, where there's a narrowing stricture there in the spine. That can also produce cramp-like pain in your legs. That pain usually worsens the longer that you walk. Walking in a slightly flexed position, such as you would like when you're pushing a shopping cart ahead of you, that may improve or it may delay the onset of your symptoms. Mineral depletion, like potassium. A lot of times if you're dealing with a lot of cramps, try throwing a banana in, eat a couple bananas a day, because too little potassium, calcium, or magnesium in your diet can contribute to leg cramps. Diuretics, medications that are prescribed for high blood pressure, they can also deplete your body of certain minerals like potassium, calcium, or magnesium. And when your body is depleted of those, it can cause those cramps. Okay?
Lasix as well. Lasix is another one that we often take with MS and if we have a lot of autoimmune disorders, and that will deplete us of potassium. So get your levels checked. You might need to take a potassium supplement along with your medications, and that might be causing all of these cramps.
That's so true. And, there's certain, risk factors for, muscle cramps as well, outside of, MS. Number one is age. I don't like to admit to that.
Yeah. And I'm a couple years older than you, so yeah, let's not admit to that one.
Right? Yeah, it could be age, like kind of as you, age a little bit, things kind of need a little bit of WD-40, to kind of work right. But
it's true.
But, yeah, it is. Age can get you. Older people, lose muscle mass, so that remaining muscle can get overstressed more easily. That's so true. And also, when people are in pain, they tend to walk differently, so that they can, they may, lean more to one side than another. Okay, but they're putting pressure on that side that, on their better side, and it's throwing them off. So then that can cause more cramps too. Okay, please keep that in mind.
Yeah.
Being dehydrated.
You'll also do that with your shoulders as well. People don't realize that. And your therapist, your physical therapist, will tell you, that you're guarding. You're guarding. That's what they mean. You're guarding against the pain, and you're just constantly constricting your shoulders, and they'll feel like hard rocks. And then you'll cause those, those cramps, and that spasticity will just get kicked off, and then it's a whole thunderstorm of those symptoms.
Yeah. And that's like for women, it's important to think about your purse, okay?
Yeah.
If your purse weighs a lot and you're carrying your purse on just one side, because we all are pretty much, as women, we'll carry our purse on one side. If that sucker's heavy, guess what? You're putting a strain on that shoulder, which is also straining that side of the neck. So either take some stuff out, because I know I got my whole house pretty much in my purse.
And if my husband's listening, he's cracking up right now.
Yeah,
I'm guilty.
I don't need it. I don't need my whole house like carrying around with me in my purse, but I still do it.
Right.
So take some stuff out, or, kind of make yourself switch it a little bit.
Yeah.
But, best advice, really, because my doctors get on to me for it, is to go to a smaller purse, okay?
Yes.
Because that can cause strain on your neck, as well. Again, being dehydrated is very important that we stay hydrated. That's with age, that's with being young, that's with anything. Body's 90% water. You got to make sure that you stay hydrated. To become fatigued and dehydrated while participating in warm weather sports will develop a lot more muscle cramps. As we know, pregnancy, that'll definitely do it. Boy, talk about getting woken up and just screaming. Yeah. Because like those cramps are bad, because that baby's going to get what, baby's like, hey, mama, I don't care. I'm taking whatever it is that I need, and if I leave you without, so be it, But, muscle cramps are very common during pregnancy.
Yeah, one of those come to Jesus moments I had, and I have bilateral TN. So I have the suicide disease here. And one of the worst come to Jesus moments I had was I was pregnant with my second son, and my mother and I had walked the mall, and we had gotten, we walked out of the mall, gotten into her car, and I just sit down in the passenger seat, and it hit. My feet, my toes, I couldn't move them enough to get rid of it. I couldn't walk it out. There was the people in the parking lot thought that I was crazy. I was screaming, moaning, twisting, and pregnant. So it was not a pretty sight. And I could not do anything.
I get them, and it's like you're moaning. You know what I'm saying? Because it hurts so bad, you don't want to scream.
Right.
And it's like everybody's looking like, girl, what are you doing?
What's wrong
you
with
know?
you?
Exactly. It's like, what are those noises coming from you? You know, but it's like, you don't understand. It hurts. You know.
Yeah.
Yeah. That's painful. Also, to you guys, just please know that there are certain medical conditions like diabetes,
Yes.
Nerve pain or nerve damage, neuropathy. If you have a liver condition or thyroid disorder,
thyroid.
But very important to stay on top of your lab work, getting frequent lab work done, checking your liver panels, thyroid, all of that. It's important to get that stuff done, and too important to be communicating with all of your doctors and making sure that you're getting stuff done. Because again, as Erica said earlier, when these things start to happen, if you're letting them know, then they can be like, you know what? Wait a second. We may need to take a look at this. You know, and then they may, have a lot easier time figuring out what's going on. So.
Yep, that's true. Looks like we do have time for one more, so let's try to get that in. We have another one coming offline from #AskMS&Me. So I have an embarrassing question. So I can't control my bowels from time to time. Do you think this is MS related? What should I do? I deal with this personally, and it can be one of the most embarrassing issues that we deal with in public. Especially, it can make us isolated. There can be, it happened to me first time at work, which I felt was humiliating. I survived. We get through these moments, especially when we find out what's going on and we understand it. But that doesn't erase that memory of having to go back to your desk commando. But fewer people, it's true, that's what happened. Fewer people with MS experience bowel incontinence than constipation. So it's not as common, but it can be one, like I said, of the most distressing. So we need to speak to our doctor with this. We need to get an assessment. And an assessment is generally the first step to managing bowel incontinence. A thorough assessment will help a health professional work out if the problem's likely MS or other factors. To assess to the extent of any nerve or muscle damage, and to recommend the best treatment for you personally. They have to ask you a lot of questions to see how they can help you. It might seem embarrassing or intrusive, but it's best to answer fully, just full disclosure, so they can figure out what's going on. They'll ask you general questions about past operations, childbirth if relevant, your diet, fluid intake. They might also ask you to keep a diary of showing when your bowel's open in the toilet, when you have a bowel accident, or if you were wearing a pad when you needed to change it, how much. It can be embarrassing and uncomfortable, but it's vital to solve this or at least address what's going on to cause it. The medical staff will examine your anal sphincter muscles, but they can only really obtain an accurate evaluation of the squeeze pressures by using a test where a small tube or balloon measures pressures in your anus. There are other tests that find structural problems like tears in your sphincter muscles. An ultrasound, which I had to scan the sphincter muscles, or x-rays help the medical staff to assess the workings of your rectum and sphincter. We can have the x-rays I had, you can have that balloon test, you can have colonoscopies. There's all kinds of tools that can give them the whole picture besides your journal and your answers to put that whole picture together. Tips for managing bowel incontinence. Once it's diagnosed, that would be a balanced diet. You may be able to improve things by making changes to your diet. For example, high fiber foods, caffeine, milk products, chocolate, alcohol, spicy food, artificial sweeteners. They can all have that effect of producing the loose stools for some people. I've actually used those when I've had the constipation issue to go the other way. Arrowroot biscuits, marshmallow sweets, ripe bananas, these can all make stools firmer. So it's worth experimenting, like I said, to see if you can identify anything that upsets your control or makes them firmer. Okay, so a regular and comfortable bowel routine is just imperative to establish. A regular routine for going to the toilet can help by, putting that plan in place at a time when your bowels are most likely to open. For example, 20 to 30 minutes after a meal or a hot drink. If you have to set a routine and can feel comfortable and relaxed, it can help encourage the bowels to develop a regular pattern. Medications. Some medications in particular, any that you are taking for constipation may be contributing to your incontinence. There may be a fine line between helping, like I said, with my case, your constipation with laxatives and causing bowel incontinence. Steps to control leakage and diarrhea. You can take those anti-diarrheal drugs like Imodium, may be effective in treating loose stools, but sometimes codeine phosphate's used. So when you're constipated, bowel leakage may stop you, clearing your bowels completely. For example, like a suppository or enema might be used. So if not, you might need to combine, with caution and advice from your physician, a treatment that empties your bowels completely and one like loperamide. So some people may have been taught to wash out their lower bowels. That might be in your country, that might have been a routine, but you can also be taught to stimulate your local reflexes with your fingers. So it's called digital stimulation. So there are techniques you can be taught. There's sphincter exercises, just like we know the Kegels, especially women know the Kegels, but there are also sphincter exercises for strength and control.
Right.
There are actual, bowel programs and incontinence programs, at many therapy centers, and they will teach you this. And you can set alarms to remind you. With our MS, sometimes we have to be reminded. So there are many, many things we can do. My own son actually is going through the same thing, and we've had to go through the same program with him, and it actually is working. He is now continent again, going back to school, which has been a blessing. But we're short for time this week. We've shared so much wonderful information. Anisha, thank you for joining me again as my sidekick and giving all this wonderful information.
You are most welcome. Thank you for having me.
Oh, it's always a pleasure. So guys, if you want to get those questions in for next week, use hashtag AskMS&Me on your social media accounts, or again, just contact us through www.msmemedia.com. Have a wonderful week.